Thanks everyone. Thanks for allowing me to speak this afternoon. My name's Rebecca Doyle and I'm a nurse researcher at Children's Health Queensland. And I'm a member of the HREC there as well and have been for the last 5 years or so. Firstly, I'd just like to acknowledge the traditional owners of the land. In Brisbane, it's the Yagara and Turrbal people, and pay respect to elders past, present and emerging, and extend this respect to all First Nations people in attendance. Oops. So at Children's Health Queensland, we're a large referral hospital for the state, and we see a lot of critically ill children. We know that critically ill children are entitled to the best medical care based on the best available research evidence, and rigorous research evidence informs clinical decision-making and advances medical knowledge while ultimately saving lives and decreasing the morbidity of critically ill infants and children. To provide this evidence-based care, we need to conduct research in this unique population. Children are not little adults, and it's not simply a case of conducting research in adults and translating the findings into paediatric treatment. In the emergency and intensive care environments, it can be commonplace for children to undergo emergency treatment or receive medication not supported by quality scientific evidence. We're all familiar with the ethical principles of beneficence, non-maleficence, justice and autonomy. But when we think about critical care research, we may need to consider these principles from a different perspective, with the understanding that sometimes it can be challenging to conduct research in this environment. We know that beneficence is to act with the participants' best interests at heart, and this also includes promoting their welfare by providing the best care. Autonomy in the paediatric population has its own complexities. Usually autonomy is the right to self-determination, but in children, this usually falls to the parent or the caregiver to make an informed decision about the treatment of the child. Justice refers to fairness and inclusivity. So should we think about this in terms of the right to be included in research even when unable to provide informed consent? And non-maleficence. This is a big one because by using unproven treatments and medications in the most vulnerable and severely ill patients, there's a very real risk of harm. One of the ways we uphold ethical principles is to obtain prospective informed consent from a parent or guardian. But what happens when the intervention is part of immediate life-saving care and there just isn't enough time to obtain prospective consent? Do we abandon the research because we can't tick the consent box, even if it means not finding a way to deliver better health outcomes or to save more lives? Sometimes the theory of prospective consent is out of sync with the reality. The literature cites many other challenges to prospective consent in paediatric critical care research. They include distress. The parent or guardian may be extremely distressed by the child's condition and does not have the capacity to provide consent. Deterioration, rapid and unexpected deterioration of the patient is typical in this cohort, and delay caused by distance. The parent or guardian may not be present at the time. The child may have been transported without the parents, who may have been even injured themselves. And delegation, the child may be being cared for by others who are not the legal guardian, like a friend or a relative. So what do we do? It's a balance between what we find ethically acceptable and what the scientific ideal is. If prospective informed consent is the only option for time-critical interventional research in paediatric critical care, the consequences may be recruitment difficulties, compromised study validity, and selection bias. Results may not be generalisable to the wider paediatric intensive care population if severely ill or injured children are less likely to be included due to consenting difficulties. If these children are not included, the study population may not accurately reflect the target population, thus undermining the generalisability. So the proposed alternative is deferred consent. Deferred consent occurs when a patient is enrolled in a trial and treated according to trial protocols before explanatory discussion or request for consent has occurred. It may also be referred to as delayed consent, consent to continue, or research without prior consent. A distinction should be made between the terms deferred consent and waiver of consent. Waiver, as referenced in the national statement, refers to any research occurring without prospective consent, thus encompassing deferred consent. While a waiver of consent may include research that never obtains consent from a participant or legal guardian, deferred consent implies that consent is obtained at some stage following the intervention. So at Children's Health Queensland, we saw 22 research projects that were submitted between 2013 and 2022 that specifically requested the use of deferred consent. 82% were granted approval to use deferred consent, while the remainder of projects were approved but restricted to the use of prospective informed consent. Consideration of these projects elicited robust discussion amongst the committee members, and the national statement provided little clarity during the decision-making process. The committee developed a position paper to assist in the decision-making process and to provide information to researchers. I've just got a couple of case studies here. Some of the details have been changed to protect the confidentiality of researchers. Ideally, it would be great to put up the case studies and see what you guys thought about them, but it's a little bit difficult over the Zoom platform, but we'll go through them anyway. So the first study was a research project proposed by the team in the Children's Emergency Department. It was a randomised controlled trial comparing the use of 2 IV fluids for trauma patients suffering severe blood loss from hypovolemic shock. Hypovolemic shock is due to a critical loss in the circulating volume of blood. If left untreated, it can lead to multi-system organ failure and death. Both fluids were used routinely, dependent on the treating doctor's preference, but there was no research evidence to suggest one was better than the other. These children were critically unwell and needed immediate treatment to save their life. They often arrived unaccompanied by ambulance or chopper, and if the parent was present, they were usually very distressed. The researchers asked for approval to use deferred consent and had appropriate plans for when they would follow up with written consent and what they would do if the child died before they were able to obtain consent. So what would we do? So this study was approved for the use of deferred consent for the following reasons. The treatment needed to be given urgently to save the child's life. It was not reasonably practical to obtain consent from a legal representative because it's likely no parent or guardian is in immediate attendance, and if they're present, the situation is sufficiently distressing to the parent or guardian that's probably inappropriate to approach for consent. There is clinical equipoise. It's generally unknown which treatment is superior, and both treatments were already used as standard care. The proposed timeframe to obtain consent is appropriate, and they had a plan for the instance of the child dying. Case study 2 was a study in premature babies in the neonatal intensive care, investigating a change in the formulation of intravenous feeding. It was a new formulation, so it wasn't already being used in the NICU, but there was some safety data from trials in older babies suggesting it was safe. The feed formulation had to be administered in the first 24 hours of life, so it wasn't particularly time critical. Researchers thought the mothers recovering from emergency caesareans might find it challenging to provide consent, and they also flagged that babies were often born out of hours when research staff were not at work. They requested the use of deferred consent for all babies in this cohort and said they would obtain written consent within 72 hours to allow for long weekends, etc. And they didn't provide a plan as to what they would do if babies died before consent could be obtained. So this study was approved by the HREC, but not with the use of deferred consent, only with the use of prospective consent. The intervention was not part of standard care, and it may have carried a higher risk. It was considered reasonably safe based on the existing safety data, but it carried enough risk that parents should decide on the child's participation before they were included. Administration window was 24 hours, and this seems ample time to obtain consent from a parent. Although the mother may have been recovering from surgery, her capacity to consent may not have been affected, or there may have been another parent present to provide consent. The absence of research staff after hours is not adequate justification to use deferred consent. If clinical staff are receiving training to administer an intervention according to protocol, they should be able to provide adequate information to the parent and obtain consent. Convenience to the researcher is not a reason to use deferred consent or to obtain written consent days later. Deferred consent should never be the default. Prospective informed consent should always be obtained if possible as the first preference. There was no plan for the instance of the child dying. Would the data be destroyed? Would the parents be approached? So where to from here? At CHQ HREC, we're developing a decision-making framework to assist with the process of considering the use of deferred consent. It needs to provide some clarity to researchers about when it would be appropriate to apply for the use of deferred consent. And this would include criteria discussed in the case studies. Is the intervention time critical and life-saving? Are the practicalities of prospective consent a challenge? Are the parents present? Are they too distressed? There also needs to be concrete guidance for HRECs, clear guidance that follows moral, ethical, and scientific standards. What is the risk to the patient? Is there any reason to think a parent would not provide consent? Is there clinical equipoise? Is there any other way the research can be conducted? The framework needs to prioritise the safety of participants and protect their rights and those of the family. What will be the timeframe to obtain the consent, and what steps will be followed if a child is discharged from hospital before consent is obtained? What steps will be followed if a child dies after treatment and before consent is obtained? It also needs to facilitate transparency, to put some reporting measures in place to ensure the process is used appropriately. This may include reporting the number of participants recruited using prospective consent versus deferred consent, the reason why deferred consent was used, example, the parents weren't present or too distressed, time from the intervention to the written informed consent, the number of participants who refused consent, and all parental complaints relating to the consenting process. We know high quality research is needed to advance care for critically ill children. Without it, we're groping forward in the dark. It has to involve children. Adult data isn't necessarily applicable. Consent is an important principle, but it can also cause issues in time-critical interventions because parents or guardians may not be able to give immediate consent. So a balance must be struck. Deferred consent is one way through this, and requests for such are increasing. The national statement doesn't offer much guidance, particularly for children. So we need to think about some kind of framework for consistency and clarity for HRECs, families, and researchers, and to put some scaffolding around the process. We've published a paper on the importance of deferred consent, and we hope to be able to share our decision-making framework with you in the near future. Thanks.
Perfect timing, plenty of time for question. Congratulations on that article as well. I guess I'll start. The first question is in terms of what your current work on this is. What's the global practice? What's the rest of the world using when it comes to deferred consent?
So several years ago, I think it was the European body that's similar to our NHMRC tried to stop the use of deferred consent and said prospective consent should be used for all research. And they saw a rapid decline in their research studies, especially their clinical trials in intensive care and emergency. And so they've reneged on a lot of those directives and are trying to make provision for deferred consent. And it seems to be like that worldwide, that there is some provision for deferred consent, but there's really no clear guidance anywhere, and it's still contentious.
Yeah, and I guess getting that balance between the kind of logistic of running trials and recruitment and so on and so forth. Just checking with the audience whether people can actually put in the Q&A. I was incorrect saying that in the chat, but the chat is disabled. So if you can, on your Zoom, click on the Q&A and type in your question. I have a follow-up question while we're waiting if there's any questions coming through. In this work, have you spoken to the parents and just to hear from their perspective and their view what would work for them, or in terms of the lit review out there, anyone sort of look at in this almost like looking at prospective versus defer, or speaking to the parents to see their view, because it'd be interesting to hear and see from their perspective as well.
Yeah, we haven't done that locally, but some of the literature has looked at parents and even kids themselves if they're old enough. And it was as you would expect. It was dependent on the study. If it was pretty representative of standard care and low risk, they were quite supportive of it. If it was an experimental treatment or drug, they were less inclined to do it. It seemed to depend on their understanding of the study too.
Yeah.
There's also been a little bit of work done talking to parents of kids that have died, and that research seems to suggest that those parents do want to be approached, and there's a thinking that they would like their child's life to have meant something, and they were quite happy to be included in that research. And I guess it's just the sensitivities around approaching them that was the nuances with that.
Yeah, it can be. I can imagine it's a pretty sensitive time as well. But perhaps if there's that willingness to be involved, I think it'd be great. And then lastly, in terms of your current work, how is that sort of in the Paediatric Ethics Committee network in Australia? Has there been like a unified views, or is it still sort of somewhat contentious?
It's a little bit contentious, and certainly some committee members have different views on it. I think I've got a background in paediatric intensive care nursing, so I think I was always pushing quite hard for it. But I think there's definitely a recognition that we need to conduct the research some way, and whether or not deferred consent is the answer, whether we should be concentrating more on the design of the study and trying to approach it from that perspective.
All right, this is actually a question came from Tanya here. So you've got about a minute to answer this. Is it reasonable to use deferred consent for mental health patients admitted to ED with possible life-threatening conditions?
I guess we'd have to know more about the study, and it would depend what they were doing. I think that it always needs to be the same risk as standard care, if not slightly more, but I think it would definitely be all about the risk, and it would have to meet those criteria that we talked about, that whether the intervention had to take place really quickly, and if it didn't, if it was for convenience or just because no one was present with them, maybe we'd have to rethink it and wait for someone a delegate to provide consent.
Great. If you can stop sharing the screen, and I'll ask Sashika to share the screen. While we do that, if you can answer the question either live on here, live here, or through the Q&A here. What about tension between treating doctor at the moment and ethics? Are they thinking about ethics even? So Sashika, if you can share the screen. Beck, would you like to answer that, or type?
So our ethics committee always has a preference that the treating doctor doesn't recruit or consent to any study, that an independent research staff recruits or provides the information, and then the family could ask the treating doctor for their advice. It's difficult when there's small cohorts of children and that is the treating doctor, but that would always be our recommendation, that it wasn't the treating doctor that was providing the consent information at that point. They would be following protocol, but